I mean, that was a fantastic presentation of anecdote, selected publications, and emotive case reports. So, I mean, I've got to say thank you. That's just one page of my rebuttal, and I'll try and get through as many as I can. So we seem to have a different definition of default technique, and perhaps the Oxford Dictionary does too, where it seems to suggest that in fact default is not the absolute, and I wouldn't suggest that either. It isn't the one and only. It is seen as the standard or the go-to technique. So it would be simply something that you offer, but that would be the technique that would be your immediate go-to or standard, if you like. Now, actually, the title was just generally any ASA patient, but I mean, that was going to be too easy. So in fact, I asked for it to be ASA 1, because surely everybody here would realize that the benefits of spinal anesthesia and anything greater than ASA 1 patient completely outweigh a general anesthetic. So I wanted to point that out and make that obvious. Now, I also never suggested at any time that every patient would have to be awake, nor that they could actually, would have to see the surgery if they didn't want to. So they don't have to see the surgery. In fact, I would describe to them how they may not see the surgery. And of course, I would offer sedation if they like. One of the first questions that I ask a patient having an arthroplasty is, would you like to be awake or asleep? Actually, that's not the first. The first ask is, have you got any ideas? And then awake or asleep, and they choose. Doesn't mean general anesthetic or not. It's sedation, general, something like that. The second question I ask them is, are you averse to an injection in your back, the epidural? Most aren't. They're just not bothered. So that's why in my practice of arthroplasty, I tend towards sedation with spinal. Which other point? Yeah, so duration. I mean, look, there are loads of studies. You can find some studies that take a lot longer and all the rest. And I think, yes, on average, most of the studies will show that it does take about 6 to 8 minutes longer to do a spinal anesthetic. There are lots of ways of getting around that. The time is really saved on the patient leaving the operating theatre. What you can do, and I forget the correct term, Ben might remind me about it, but you can stack your patients, so you could actually start the spinal anesthetic before you've actually finished. So in that way, you completely remove any time to actually do the procedure, which you can't do with a general anesthetic. So the patient can actually go in immediately ready. I've said again, what's that nice anecdote of another 20 patients? Yeah. Yes, I've done that too. There is a point about a lot of the older studies that they do look at bupivacaine, and a lot of them are bupivacaine in day surgery. And I think there are a lot of problems with bupivacaine in day surgery. You do get a higher failure rate because the drug just wasn't designed. In fact, it's an off-label use using it in such a low dose. So that's not what the drug's actually meant for. So you do get a higher failure rate. You need to add adjuncts like opiates so that it can actually work. And that's where you get your side effects, particularly urinary retention. It's interesting that if you look at studies of discharge time, they're completely variable. Some are short, some are long. That's because it's a long-acting drug, so it's not for day surgery. There is an issue with discharge times, and I do agree here with Sean that we do need a lot more study to be done here. I think there's a big difference between a patient ambulating and then being ready for discharge, and the biggest issue comes down to passing urine. So if any of you are members of BADS, you may have read the handbook on spinal anesthesia and day surgery. And that shows us very clearly what we actually need to do when the patient's ready to go home. So if you don't have an enlarged prostate over 70 or a higher risk at all, you simply go home without passing urine, and nobody actually has a problem. And that doesn't hold back the discharge time. So that, you really need to have an organizational restructure. If you're going to change the way you do things, you're going to use a new technique, you need to change the whole process to get the benefits. And a lot of these studies hadn't yet done that because they're very early sort of days of looking at short-acting drugs and in spinal anesthesia. So that's why there's a big disparity between when they were kind of ready to go and actually did go home. I think there are, you may well say, well, under a general anesthetic, all these complications, they're small things. Well, I mean, a corneal abrasion, dental damage, sore throat, laryngeal trauma, all those issues, they may seem small to us, but they're really big issues to patients. So much so that in the States, they account for the greatest number of closed claims against anaesthetists. So these little things that we don't consider to be a problem, they are big issues to patients. When it comes to postoperative nausea and vomiting, you know, I think even with general anaesthesia, we do a bad job. And if any of you have read Gann's consensus guidelines on postoperative nausea and vomiting control for day surgery or ambulatory care, you'll see that he's very clear in actually saying, you know, how often we do get postoperative nausea and vomiting from general anaesthesia. And in fact, their number one strategy to prevent people getting sick is to do a spinal anaesthetic. So, well, I don't know. I mean, maybe they're all wrong. That's quite possible. Have I got more time?
No.
I think I do.
I thought you might say that.
No, failure. I mean,
One more point.
Only 30 minutes now.
Well, I'm taking a bit of time back from you, Sean. So, look, with regards to failure, you know, yes, you can select those studies that Levy published in 1985. I'm not sure what he was teaching people were doing.
2016.
Levy was 85, actually. But
Tonkins.
Oh, no, you're showing your study on the failure of spinal
6%.
anaesthesia. So, and, you know, I would agree. You know, you are dealing with young, fit patients here. I mean, you know, you should be able to get a spinal in first pass. And I agree, if you can't, you bail out. And I say that to patients too. I say, look, we'll do a spinal anaesthetic. If it hurts you, let me know. If I can't get it in, I'm going to be honest, I'm going to stop, because I'm here to look after you. You know, that's my sole job. So, yeah, absolutely, we're just not going to do that. But if failure rate was such a big problem, why are we still doing it in obstetrics? So that crash section that comes charging in, we go, oh, we better put a spinal in quickly. We go, well, hold on, no, it's going to fail 1 in 20. So, but we're still doing that. So maybe we should go to ASA this year and actually correct them, because they've been doing a lot of harm. I can't understand that.
I think we need to leave it on that slightly controversial note.
My final point.
You will not make your final point.
The bizarre inconsistency with dural punctures or lumbar punctures in young medical patients. Sure, they come in with headaches, but they stick these massive big needles into them, 21 gauges with iodine, and you know, none of them come back. I mean, how many of you have done a blood patch on a medical patient that came in for an LP? Okay, too many. But not that many. It is not that many. You know,
Okay.
Considering the technique they employ, you know,
Thank
really,
you, Ollie.
it should be more. Thank you.
Okay,
really got
Sean,
one
you have
thing.
the rest of the day to rebut.
I've got one thing I must say, I'm sorry.
1 minute.
Yeah, no, go on, you've got 5
One
minutes.
thing is that I have no competing interests. I forgot to say that at the beginning. And otherwise, I rest my case.
It has been rested. Any questions?
Really? Okay. That was too quick. Fine. I used to be undecided, now I'm not so sure. Any questions from the audience at all?
Or comments?
Or comments?
Or personal experience?
You said my anecdote of 20 patients was anecdotal. How many of you does that description of my last 20 patients in GA's day case, how many of you does that reflect your practice? Hands up. Thank you. It might be an anecdote.
How many of you fail to get a spinal in 5% of the time, 1 in 20? Okay, more than that. So no one. So you all do better than that. Okay, well, there you go. I'll rest my case.
Could I remind you that the chloroprocaine paper was published in 2016 by Tonkins, and that showed a 6% failure rate, but that wasn't necessarily a failed dural puncture rate. It was a GA conversion rate. Is there a question here?
We have one question here at the front.
With the short-acting drugs, especially my colleagues are unaware of actually when to use them, and the slide that Ollie put up to actually show which drug to use with duration for which procedure. I think is extremely valuable, and I think that's the message that we should give to our colleagues, because most people don't know. They just want to ask 3 mils of what? 3 mils of bupivacaine, 3 mils of prilocaine, they just want to put 3 mils in of something, and I don't think they know which 3 mils to put in.
Okay, any other questions?
Can I just say that's not my slide, but that's Emmanuel Gunz's slide, but just to make it clear.
Oh, we have a question on the slide.
Sorry, I don't have a question, just an advert for the British Association of Day Surgery booklet, because there is some recommended recipes in there for how much to give Mornay, if anybody wants one. Thanks.